Thank you so much. The next session is live cases from Saudi, Dr. Fazila and Dr. Sujata. Sorry, from Bangladesh. Sorry. The moderator for this session would be Dr. Haythan. I request Dr. Mahpekar Mashhadi, Dr. K. Gopal Krishna Garu, Dr. Surya Prakash Garu, Dr. Mamas, Dr. Siko, Dr. Zakia, to please chair this session.
Dr. Fazila Malik,
Yes.
at the outset, I would like to thank you very much for doing this live transmission free for us. A big round of applause to Dr. Fazila Malik, who is our neighbor and who has been kind enough to do this live transmission free for us. Thank you, ma'am.
Thank you. My pleasure.
Yeah, welcome, Dr. Fazila. I'm Dr. Hetan here. Will you describe your case? We have a 20 minutes because we are having a 20 minutes for your case presentation and the 10 minutes for discussions.
Right.
So will you? Yeah.
Okay, great. So let me first go to our a bit about Heart Foundation. Can we have our slides, please? Can we have our slides? Yes. So those of you who have never visited Heart Foundation, National Heart Foundation Hospital and Research Institute is a non-government, non-profit organization. It is a 565-bedded tertiary cardiac care hospital. And at present, we have 5 fully functioning cath labs. And over the next couple of months, we plan to have 7 cath labs. Can we go to the next slide, please? So we are a fairly busy center. Last year, we did more than 25,000 procedures in our cath labs. And of these, more than 8,000 were PCIs. And we started doing left main PCI on a regular basis since 2007. And last year, we did around more than 590 left main cases, and we've an experience of more than 4,335 left main cases. So this is our patient, a 62-year-old female patient, hypertensive, diabetic. She's a smoker with COPD, and she had a long history of chronic stable angina. She was admitted in our hospital with unstable angina with an ejection fraction of 53%. And this is her angiogram. You can see she has a 80% left main stenosis starting from its ostium. LAD has a 80 to 90% stenosis in its proximal segment. And the LCX is a dominant vessel having a 50 to 60% stenosis in the proximal segment, but the ostia doesn't look that bad angiographically. And angiographically, we can also see quite a bit of calcium in the left main as well as in the proximal part of the LAD LCX. The RCA is a non-dominant vessel, and so she has left main disease with a left dominant system. We urged her to have CABG done, but she's absolutely against it. And considering her very bad COPD, the surgeons were also a bit reluctant. So today we are doing her PCI. So we started a bit. Let's go to our first slide. And this is our syntax score. Can we go to our slide, to our the live monitor, please? Yes. So this is today. We just started with the left side just like 20 minutes ago. And so wiring the vessel was a bit tough. The lesion was very tight. So we first go to the LCX with a BMW, and then we wire the LAD. After wiring both vessels, we thought about the calcium, and we were able to take a balloon, and we did pre-dilatation with an NC balloon. You can see that the balloon didn't go that easily because there was quite a bit of calcium there. We did further pre-dilatation. At this point, the patient became a bit unstable. She's got no support system. So we gave her a bit of intracoronary adrenaline. This is how it looks after NC balloon pre-dilatation. And then we wanted to do IVUS for this patient, but unfortunately our IVUS machine malfunctioned, so we had to do OCT. So let me show you our OCT runs, and then you can decide on what strategy to follow. So in the OCT, we found that there was quite a bit of calcium in the proximal LAD, but it was not that thick, around 0.4 millimeters in thickness. But the calcium in the left main was quite significant. It was quite thick, more than 0.5 millimeters. But we felt that as our balloon had gone, maybe we don't need any atherectomy device. We will get away with a scoring balloon. So this is her. Can we go to the OCT run, please? So this is the OCT run from left main to LAD. And this is where you can see the calcium in the LAD and in the proximal left main. This is the left main. And here we have calcium in the proximal LAD, and we've managed to do a bit of pre-dilatation as well. After that, we did a run from left main to LCX. And in the tightest portion of the left main, it's quite tight even after our pre-dilate. This is the tightest portion. And it's the lesion is so the lesion length is around 30 millimeters. Okay. So we've taken a so then we go from left main to circumflex. And in the left main to circumflex, there is a lesion in the proximal part of the LCX, but it's not that significant. It is a bit significant, but the ostia is relatively free of any disease. So this is a left dominant system, significant left main disease having some calcium, and the LCX we feel we don't need to go for an upfront double stent strategy so far. That is our thinking. So any comments on this? But actually at this point, the patient started retching and vomiting, so we had to proceed more.
Good morning, Dr. Fazila. This is
Yes.
Dr. Sarita Rao here.
Hi, Sarita. Lovely to hear your voice. How are you doing?
Perfectly fine, Dr. Fazila. Lovely to see you.
Thank
So,
you.
this is a very interesting case. And from what you have shown us in the OCT runs, so the ostium of the circumflex appears to be free of disease. So we were just discussing that I think you would like to go provisional first is one. Second is the calcification is there, but it's not so much. So are
Exactly.
you going to approach it with a cutting balloon, or would you want to use rota? Do you think cutting will be enough in this case?
That was our feeling as well. And this is a left dominant system, no support from the right side. So here we would be very hesitant to use if required, we would use an atherectomy, but here we feel that we can get away with a cutting balloon. And that's what we did. We used actually a scoring balloon here. Let us show you. So we used can we go? Please.
What was the size of the scoring balloon
Yes,
that you
yes,
used?
we just used it. So let's go previous slide, please. Yes. So
What is the ejection fraction of the
this
patient?
is the OCT run, and then we take our scoring balloon. So we, as you can notice, we've kept our catheter disengaged because she's not tolerating the catheter to be engaged, and we're giving minuscule dye so as she doesn't feel bad. And then this is how the vessel looks after our IVUS run. And then we couldn't take the picture of the. Oh, I'm sorry. So, so patient was a bit unstable. So we took a 3.5 by 10 millimeter scoring balloon, and we did pre-dilatation. And after this is how the vessel looked. So it looks a lot better now, I think. And so now we, as you have rightly said, we have also decided that we think we need to do a provisional stenting here. And that is what we have proceeded to do. We've taken a 3.5 by 38 stent and a drug-eluting stent, positioned it at the ostium right now. and we have just deployed it. This is just where you found us
Which
because
stent is this?
it's a synergy.
Hi, Fazila. This is Mamas from the UK. What size do you think the left main is going to be on your intravascular imaging? Because that will really determine whether you're going to be able to expand this stent to oppose the left main body.
If you remember, we did an OCT, and in the OCT, our size of the left main was. Could we go to that, please? So this is the left main, and so it's 3.9. So we took a 3.5 synergy, and we plan to do post dilatation. And after that, after proximal optimization, we will again do an OCT run to see how things evolve.
Like Fazil, this is Dr. Prof from India. Yeah, you see your strategy is correct. Your one way, the left dominant circulation, left main stenting is a different ball game. First thing. Second is you're lucky that the ostial circumflex hasn't much disease. Third is the calcification is that it can be maybe tackled by the cutting balloon than the IVL or a rota. A rota may not be because two wires you have to keep compulsory, you have to gel, you have to protect the left circumflex. I agree with your strategy. And the new all generation stents, 3.5 stents in the left main now, this Megatron, this Ultimaster, and new stents, all these things can be stretched up to the more than 4.55 like that. That's one advantage. And one important thing is that how you position the marker of the stent at the proximal left main. Nowadays, I think too much projection into the ostium, beyond the ostium is not needed because of the part, there may be some projection to the left main already.
So we've just deployed our stent. As you can see, our LCX wire is still J. To do it now. So as you can see, our balloon inflation times, we are trying to keep them as minimal as possible because this is a left dominant system and we do not want to cause any type of ischemia or significant ischemia for our patient. So we did a pot with a 4 by 13 NC balloon. Thank you. And our balloon became quite bulky and it was a bit of a struggle to get it out, but we've just got our balloon out. Now, as we've got a jailed wire in the LCX, we're keeping our balloon stent, our guide catheter a bit away. We don't really want to mess up with the ostia of our stent. And now we'll have a look and see how the circumflex looks. We'll take a cine now. Yeah. So now that we've done our proximal optimization, we plan to rewire the circumflex and remove the jailed wire. So I'm taking a fine cross with a BMW wire to recross the circumflex.
How well expanded do you think the stent is in your left main?
Even if it's not totally expanded, I've done proximal optimization with a 4 by 13 millimeter, and I went up to quite high pressure, so it should be all right. And we will be doing reports subsequently. So, and after that, we'll also do imaging just to make sure that there are no under expanded struts or any malapposition. So we will definitely make sure that our stent is properly apposed when we before saying goodbye to our patient from the cath lab. So I'm taking, the wire is already in. I'm taking my micro catheter. We might need to increase the curve of our wire. The wire is a bit too straight, I feel. So maybe we need to So it's gone to a small branch. Let's see. I think I'll need to wire. Can we check, please? Is this a... Yeah, so we'll just get the wire out and increase the curve because it's not taking the... So I've kept my micro there for positioning, and then I'll create a greater curve on my wire and then go into the LCX. Can we change the view, please? This is the view that we were already in, please. Yes, perfect. So just by changing the wires, can we get it? Yeah, yeah. Now I've got the micro in, right? So I just want to change this wire to yes, I will. I'll just remove my micro first and now remove the jail wire, please.
Which wire you are using?
What?
Which wire you are using?
This is this is actually a run through.
Okay.
So we've just removed the jailed wire. Yeah, so where's our wire?
Doctor, why do you need a microcatheter for exchange in this case?
Oh, actually, you know, for whatever reason, I find using a microcatheter very easy to rewire my vessels. So this is something that I do. Most operators don't do it, but whenever I rewire the LCX or I need to rewire a branch, I always use a fine cross. It gives me proper positioning of my wire. And also once you say I'm not happy with the angle of the wire or all, I can always just keep the micro there, pull out my wire and again, you know, change the angle and stuff. So that's why I find it very convenient.
Most of the times, any hydrophilic wire with a good curve at the tip is able to cross.
Absolutely. I mean, different operators have different techniques. For me, a fine cross with a wire is something that I so now we are taking a small balloon just to open up the strut of the LCX. This is not something that you would routinely do, but we're just doing it here. After that,
Fazila, would you like to image before you, open up the struts?
okay, do you want, okay, fine, sure, we can do that. So let's do a report and then do the image. So we'll do a report from the left main, in the left main to, and we also need to do post dilatation of the proximal LED. So let us do that and then do the imaging. Fine.
Imaging.
So we're taking a 3.5 by, so this is a 3.5 by 15 NC balloon for the LED. After that, we'll take the larger size balloon for report of the left main. And after that, we'll do the imaging. That's fine, right? Nimajay? So we went up to 24 with the 3.5, but now we're going to take our 4. Let's take our 4, do a report, and then do the imaging.
While she's working on it, let's discuss. How many of you would take a JL guide for this kind of a lesion where the angiogram, the angiographic catheter is damping and they have to take out the catheter? How many of you would take a JL guide and how many of you take a extra backup guide like Dr. Malik has taken? I would vote for a JL guide. Probably she's the great operator who has extensive experience and there's no anti-thing against using a guide. The second point I want to make is learn from her how much of little contrast she is using by doing a PCI, even though her kidney function is not, the patient's kidney function is normal. We have to learn from her. The contrast she is using is very, very less. She's not making the puffs we all make in doing this PCI because we are worried. That is the respect to the kidneys. So she's giving, it's a great lesson for us to learn from her. Dr. Malik, your OCT, the distal reference diameter EL to EL looks like 2.5 or 2.75.
No, the EL to EL was what, 3, I think. It was 3. For the LED, it was 3. So we'll take our OCT catheter now and from left main to LED, and we'll do our post-procedure run. And we have, as you, Sarita pointed out, before trying to open up the struts of the LCX, why not have a look with the imaging? Great suggestion, thank you. So that's what we are doing. We've done post-dilatation, and now we will have a look. Actually, yes, we wanted to do an IVERS, but here we ended up with the OCT.
And you have a borderline lesion in the circumflex which is dominant and you are planning to jail the circumflex. And have you thought of assessing the borderline lesion across a major OM in the circumflex?
Yes, we have thought about it, but let's see.
We are running short of time. Can we move to?
Yes, we'll
the
move to
live case?
Dhaka.
On
Dr. Fazila.
On? right? So we've done our post dilatation, and what we did is
Your screen is not visible.
the screen is okay, right? So we did our post dilatation, and we also actually, just to make the left main really properly, the stents properly opposed, no malapposition, what we did is actually we did a kiss there as well. We opened up the strut of the L6, did a kiss, and then did a report. And in the final result, you can see that there is no stent malapposition now. The struts are very well open, and things
But
look good.
Fazila, just after the 10, you can see it's a big problem there in the proximal LAD. Can you see
Yes,
it?
exactly. So what we were planning about that particular part of the LED, we are planning to take a 6 millimeter very small NC balloon at that LED point and go up to very high pressures. So overall, the left main, there is no under expansion or malapposition. The struts are fine. The edge of the LED is also fine. That particular point, we have also noticed it, and our aim is to take a small 6 millimeter NC balloon and do a good thorough job of post dilatation at that site of the LED. But apart from them, can we have a look at the angiographic view, please? The final angiographic view is like this. Can we go to the epicranial, please? So this was
Fazila, would you think of taking an OPNNC balloon at that point?
Yeah, we can do that as well. If so, but angiographically things look great, right? But as obviously in the but there's a bit of a narrowing there also angiographically. But what we will do is we'll take a OPN or any balloon that can go up to very high pressure and do our final there. And because in the OCT we did notice that thing in the LED. Yes.
Dr. Fazila, angiographically it looks beautiful, but it's just that we have imaging and we are seeing that, so we were just
Absolutely. So we'll
wondering if we
work on
could
that.
tackle that.
Yes, we'll work on that off screen. But so that's us from Dhaka, and thank you so much for having us over.
Thank you, Dr. Fazila. That's a great case, a very learning case. You handled it very beautifully and with all the proper steps which were followed and a great end result. Thank you so much.
Thank you. Thank you.